I want to commend the Anglican parish and its priests for starting up something like this. I think it's a very good conversation to have, and it doesn't have to be necessarily sad or horrific. And I think we could do, I think the basic impulse, which was to make ourselves a little bit more prepared, is a good one. And there was mention about dark humor, so I'll start off with a couple of stories, none of them true, but illustrating some points maybe. And one is a story of an old man who's about 96 years old, and he's dying at home. And no one is upset about this, not the least he's not upset about it either. And it's time. And he's been in bed at home for 3 weeks, never got out of bed, so time is getting close. And most of the time, he's sleeping, but some of the times he surfaces a bit and they give him something to drink and then he goes back to sleep again. And one of these times where he surfaces, there's no one in the room. And he smells chocolate chip cookies. Oh, he says, chocolate chip cookies. And he looks around and he gathers his strength and he actually gets out of bed and totters across the room and opens the door to the kitchen. And there on the table is a plate of freshly baked chocolate chip cookies. So he just digs deep inside and shuffles a little bit more forward and reaches for one, and a hand comes and says, "Ah, those are for the funeral." And, you know, he was kind of reassured that there are some things that never change, and that's good. And so I was supposed to talk, I'm not entirely sure how to talk about death, but I will look at it a little bit from the physician's point of view. And I've seen a lot of death and come to terms with it in a physician's kind of way. But when it happens, no matter how prepared I am, and I've seen all this death, when it happens to someone close to me, and I even know it's going to happen, I'm never prepared for it. It's like this huge hole that appears. And so it's true that you can be prepared for the social things, the society things that need to be done. But no matter how well you prepare yourself, it's going to be an enormous, almost like a hurricane. And I'm reminded of Marcel Proust, who was writing to a friend of his who lost his mother, and he said, you know, I'll paraphrase a little bit, but it's the only useful piece of advice that I've ever read in the literature about what to say and to console somebody who has had a death. And basically what he said was, you must remain still while this huge, incomprehensible force rolls over you. Don't agitate, just stay very still. And then slowly, slowly with time, you'll be able to revive your mother by using memory. And allow that to happen, and build her back up again using memory. But you will never be the same after this, but you'll never love less, and you'll find that as a sort of a consolation as well. So for those of you who are interested in that quote, I paraphrased it badly, but I do have it. Just get in touch with me and I can give it to you the proper quote. Now, on the physician's side, mostly what we do is diagnose. it's true there's a palliative element, but most of our stress and our efforts come from diagnosis, and it is a source of stress to physicians because death is a sneaky enemy a lot of the time. And I remember a famous, well-known person from this area who was about 85 years old, and he came to the emergency room, very graceful man. He came to the emergency room with his bags packed. And I said, so what's going on? He said, well, I wanted to check into the hospital, I'm here to die. And I said, what makes you think that? He says, oh, I just know. And so, who was I to go against that kind of feeling? I admitted him. And he spent about 2.5 weeks in the hospital receiving visitors from all over Canada and saying goodbye. And then another week or two and got completely bored and went home, and it took him another 5 years before he got it. So sometimes you don't know. But there is what to put on your gravestone. And one funny thing I read was, I told them I was sick. and we do see a lot of that. And people, especially these days, I think the level of anxiety in society has gone up. If I think back 40 years, whatever the reason is, media or telephones or COVID or whatever, but people are far more anxious than they are, and that includes anxiety about death. And that the end is here in one way or another. And so they come in, and of course that anxiety is transferred to the doctor, and we start to do tests. And I have a lot more diagnostic tools than I did 40 years ago, and ways to look at the body than I did 40 years ago. Unfortunately, sometimes they're so good as that they raise a lot of false alarms. So if we talk about breast cancer, for example, 1 in 8 mammograms will have a false positive. And this causes more anxiety because they're called back for more tests, and then even a biopsy, and it takes all about 3 months. And then they're told, well, no, everything's okay, that was just a false alarm. So the technology comes with a price, and that is the earlier you try to find something, the more likely that when you find something, it's a false alarm. So it sort of heightens sometimes the anxiety that way. And another source of anxiety is the current health system, which is not like, what's that medical show on TV, I can't remember the name, but they get all the diagnoses done in an hour. All the tests and everything like that. And it doesn't happen that way. It takes a long time. So you go into the doctor with some anxieties, and the doctor is also a little bit concerned, and then you face the current delays in the medical system. And then the delays come back, and then tests are finally done, and there's a level of uncertainty to it as well. Now, this is a different death than a car accident where you just, that's it, and so on, but it's what we see for the most part. And we have an elderly population here, and as you know, pretty much after the age of 50, the wheels start to fall off in one way or another, and so there's always sort of problem. And could it be the big one or not? And often the doctor in the medical system is not able to answer that. Sometimes we can with our fancy MRIs, but sometimes we can't. And what we can do, or what we do then, is cause more anxiety. So I'm just going to say, okay, so after all of this, and the anxiety and are my symptoms real or are they not? And I better go check it out. And then the doctor says, well, we're going to do more tests, and the tests take forever and ever to get. And then they come back and there's a bit of uncertainty, but then there's a diagnosis. And you say, yes, you have this terrible disease. Often it's cancer, which is called, in the medical terms, it's called the emperor of all diseases, is cancer. And that's just the beginning of the road. And I'm going to go wax a little historical, but everybody has different personalities. And so you can't say, well, you must react only this way. Everybody is different, and emotionally and psychologically, and their stories are different. So there's a variety of ways to react to bad news. And, you know, in medieval times, they used to think that there were the humors, and they used to think that physical disease came out of the various balance of humors. For example, melancholy means black bile. So if you were a melancholic type of person, there was probably something wrong with your liver or your gallbladder. And phlegmatic was from the lungs, so the wing. And that would be sort of, who cares? You just go with the flow. I can't influence it. They're very passive, the lungs. Splenetic was from the spleen, that's anger. These are fighters and angry people. But they have done some studies trying to correlate this, and I think it's generally true that the sanguine personality does best with a diagnosis of, say, advanced cancer. And sanguine is of the blood. And there's different ways different definitions of sanguine, but the one I like is that it's hopeful courage. It's more like, okay, so what's next? And then what's after that? And let's just get on to the next step. It's not passive or go with the flow, it's active, but it's like, let's just move it on. And let's keep going. And people who are of a sanguine disposition or can develop the sanguine disposition, which is mostly living in the moment and not projecting in the future and just making the moment as best as possible till the next moment. You expect the next moment. Those people do better and have less trouble with what is pretty much going to be inevitable anyways. So diagnosis is made, and then that's only the start of a whole medical system, and all of a sudden, when you thought it was hard to see your GP or your doctor or me, all of a sudden you have more doctors than you can shake a stick at. All kinds of doctors. There are all kinds of specialists. And they all look at you, and now your problem is a bit like scheduling everything. You have to travel. Very few specialists work in rural Canada. So you have to travel back and forth, and you have to hang around. The specialist might see you for half an hour or for half a minute. But they all plan what's going to happen to you, and you feel very passive. Again, it's just, there's nothing I can do about this, and I just have to make all these appointments. But it's just the start of a process which is for trying to treat whatever bad disease you have. And no one gives you an idea if it's going to work or not, or how well or what the chances are. And doctors in the health system are very reluctant to talk about prognosis, or to say, you know, if you get this chemotherapy, there's if you don't get it, it's 20% chance of living 5 years. If you do get it, it's 40% chance. Is it worthwhile going back and forth? And maybe, sort of, I guess what I'm talking about is putting the decision making, if possible, into the hands of the patient, so giving them more information. And then chemotherapy is divided into where they expect it to work, or what they call palliative chemotherapy. And I'm just talking about cancer here because it's very prevalent. There's other forms of death, obviously. And so palliative chemotherapy is meant to make your life more comfortable. It's not meant to make you sick. It's meant to make your life more comfortable. So, but that's not made clear to people either. Another thing that's not made clear to people is and this has been a recent push in Quebec, is what are called levels of care. And so levels of care are not legal documents. That's a living will signed by a notary, and probably if you come, and Nancy will be here, she can talk about that. These are just documents, and I brought a whole bunch of samples here, which you can, in French and in English, mostly in English. And that's where you can choose your levels of care. Now, I'll just read them out for you. So basically, for 4 levels of care, and goal A is to prolong life with all necessary care. So care includes all interventions that are medically appropriate and transfers if the intervention is not available in the current setting. All invasive interventions can be considered. So that's do everything. And goal D is the other side. This is more on the palliative side, which is care is exclusively aimed at maintaining comfort through the management of symptoms like pain, trouble breathing, anxiety, and so on. Interventions do not aim to prolong life. Illness is left to its natural course. And in between A and D is C, B and C. So B is prolong life with some limitations to care, and C is ensure comfort as a priority over prolonging life, but you know, you can do measures to prolong the life as well. So, you know, once in a while you get a case where, I'm sorry, and the other thing on levels of care, a separate thing is, do you want CPR, chest compressions, and also, do you want to be put on a ventilator to prolong your life? So that's sort of, you can be A, but say no CPR and no ventilator, or you could be B or C and say that, or you could be, I don't want CPR or ventilators, and I don't want any kind of interventions at all. Very useful document, at least for doctors, because it gives us a guidance in the hospital system. But it is for patients as well. And you can change your mind too. It's not a legal document. It's not like you're going to have half the kids say one thing or the other. It's quite flexible. So we have put levels of care on all the nursing homes and the private nursing homes and so on, so that people can think about it and have a little bit of an idea and decide. And it becomes quite important when you have somebody, say, at home who does not have a level of care and is dying, and something happens and they call the ambulance, and there's a big ambulance fuss like in television, ER, and they come crashing in, and no one knows what's happening, and this person's not breathing, and they intubate the patient. And the patient wakes up on the ventilator when they didn't really want that, and it's not really going to happen. So it is also very useful for patients. So I've left these levels of care documents here, and if you're interested, you keep a copy at home, and your family doctor keeps a copy in the chart, and it's usually a copy is sent to the hospital as well for some guidance. It's just again, purely guidance, you're not committed to it.
Is that covered by the living will?
It's different than a living will, and Nancy will talk about that, is actually a legal document that especially if you have families that can't, that have conflict and so on and so forth, and the person wants to maintain that. You know, there's a famous case of a doctor in Los Angeles, a hematologist, who himself got leukemia of a certain sort of rather aggressive type of leukemia. And he went for chemotherapy and it worked, but then it came back. And so he knew the odds were practically zero. So he got a living will done, and they assembled a team in the hospital of ethicists and lawyers and psychologists and psychiatrists to make sure he was in compos mentis, and he really wanted to do this and signed it. And then only 2 days later, he got really sick, and high fever and pain and so on. And around 4 o'clock in the morning, he said, "I've changed my mind, and I want treatment. At the very least, I want some antibiotics and a little bit of chemo just to catch that in." And so they tried to assemble the teams of lawyers and ethicists, but they don't usually work at 4 in the morning. But they got most of the team together, and he signed another one saying, "Do something." And then they did. And they gave him some blood and some antibiotics. And nevertheless, he died in the following morning, and the hospital got sued by both sides of the family, you see. So living wills as well have problems, but they're more legal. This is just a suggestion. It is a living will, but it's one that can be changed. And it's one that just gives guidance. Very useful. Very, very useful. So I left these here for people to pick up, and if you like, you can bring it into your family doctor, and they can put them in the, if you have a family doctor, and they can put them in the charts and send it to the hospital, and that'll give some guidance. And you keep a copy at home so that if you decided that you don't want anything done, then when the ambulance drivers come, they don't feel on the protocols that they have to do resuscitation measures. I think I'm going to end there. There's so much to talk about, and I don't want to bore you too much, but there are no, I think I'll just say that. Those are the most important points I wanted to get across. So I'm not sure if you want to, anyone want to, that's 30 minutes or so. Would you like to ask questions now? I'm totally open for any kind of questions and discussions. Or would you rather wait till after coffee?
If you just do a handwritten letter stating I, in your name, do not want to be resuscitated unless I can have a quality of life, and sign it and state it. Do you need a witness on that, or will that even work?
I don't think it would work. So remember that this living will has, first of all, levels of care as one thing, and then CPR resuscitation as a totally separate thing. And it won't work because we don't know when we resuscitate somebody and put them on a ventilator whether it will help give a better quality. I mean, we hope it will. That's why we do it. But we're not sure, and lots of things can happen when someone's unstable and has a lot of disease, from the disease or from the machines or from anything else. So we're not sure what's going to happen. So if I got a note like that that said, don't do CPR or intubate me and put me on a ventilator unless you know that it's going to improve the quality of life. It doesn't help me because I don't know. I'm much better off with something cut and dry. I have to say that, I mean, I spent a lot of my time in ICUs and stuff, and so I'm not a nihilist, but CPR rarely works. And it's kind of a disorganized and ungainly way to go, to have someone pounding on your chest and doing all that. But there are some certain specific cases where CPR is a miracle, but I would say like 90%, especially if you have other diseases, it doesn't work very well. And we generally try not to do CPR on patients who have, say, advanced cancer. We just sort of make that decision ourselves and just say it's not important. We know that's not going to work. And it's the same, some ICUs will not accept patients over 70. And it used to be sometimes I would have to, if there was a real bad intensive case and I was talking to Ottawa ICU, I would have to say, yeah, well, look, he's 80, but he writes poetry and he sings songs. Or I would try to sell it, you know, a little bit to get them in. But so admission criteria are vary from ICU to ICU, but lots of times they have an age limit.
If they had a paper like you have filled out and, you know, telling you their wishes, can the family come in and change that?
If you're unconscious, yeah, you better ask Nancy, but I think they can. And although it's a powerful document because they have said that when they were well, and the family does that at their peril. And, you know, sometimes it's the end of life, or it's a life-threatening situation, and sometimes we feel really badly